A couple of situations you might see in your practice are on the boards, namely regarding drug toxicities, drug interactions, the immune reconstitution syndrome, which you should recognize if you don't know what it is, and then what you do with antiretrovirals for your patients in the ICU. The first case is a 27-year-old HIV-infected female, a little bit overweight, who presents to the ER with tachycardia, tachypnea, and hypotension. She's been on a variety of antiretroviral regimens. She's currently on these. I think one of the problems is that as we get more and more drugs and there are more and more combinations which have specific names, it's harder and harder for non-ID people to know what the drugs are. In the ER, she has no localizing complaints, but she has a low-grade fever, not much of a fever, but she's tachycardic, she's hypotensive, she has a tender abdomen, particularly over her liver, which is large. Her liver function tests are a little bit high, but her lactate, I think in your handout it says 9, but it's 19.7. She's given saline and Levophed. So the question is, here is somebody who looks like she's septic, but the question is, what does she really have? And I didn't make this into an ARS question, but the question is, what does she have? She could have a variety of things, and you certainly have to consider sepsis as a major issue. But in fact, she is on a class of drugs which could still appear on the exam, although they're fading from clinical practice. And those are the antiretrovirals that begin with a D. It used to be DDC and DDI, although DDC is off the market, DDI is almost never used. So stavudine or D4T. And what these cause, particularly in overweight women with HIV, is hepatic steatosis, a fatty liver, and lactic acidosis. So it's part of the differential diagnosis of septic shock. If they're on one of the older drugs, D4T, which you still see sometimes, they could have hepatic steatosis and lactic acidosis, a tender liver, moderately abnormal LFTs. So look for that, although I think that really will fade away from the exam in your practice because it's just not used very much anymore. A drug that is used a little bit more is abacavir, and that can also produce a septic shock-like syndrome. I won't go into the pathophysiology, but what happens with abacavir, which is one of which you can see in a variety of different combinations, and again, the drug names are more and more complicated because there's a true drug combination that includes abacavir, there's a three-drug combination, trizavir, so that unless you know the components, you may miss that they're on abacavir. But what usually happens with abacavir is when they've been on it for a month or two, they get what they think is a viral illness, they stop the drug, and then when they're feeling a little bit better, they restart it. It's this re-challenge of people who had an abacavir fever that gives them life-threatening distributive shock, and there have been several dozen deaths of that. So these are two syndromes that intensivists should know because they can present like septic shock, and the key is obviously to stop the drug, not to treat them empirically well, you do have to treat them empirically for septic shock, but this is something you should at least recognize so that you stop the drug. The other thing just to mention is that if you see on the boards during your practice a young patient who comes in with an apparent myocardial infarction, that is being seen more and more in patients with HIV because due to the lipid abnormalities and glucose abnormalities, probably not due to their HIV, but due to other recognizable risk factors, tobacco, drug-induced lipids, drug-induced glucose, they develop very accelerated atherosclerosis. So seeing myocardial infarcts in people who have chest pain, etc., if they have HIV, is something you should look for because that will happen. The other thing you should realize is that if patients are on the protease inhibitors, and a lot of patients now are on what are called boosted protease inhibitors, which are ritonavir and something else, and there are a number of new drugs, darunavir, lopinavir. Again, it's hard to keep all these drugs straight if you're not an ID person. But what you have to realize is that these protease inhibitors increase the area under the curve for other drugs that are metabolized by the liver cytochrome P450 system. So any drug toxicity they might have is going to be accelerated by being on ritonavir because the drug levels can become astronomically high. So, for instance, they're on a statin, which more and more HIV patients are on because of their accelerated atherosclerosis and their lipid profiles. If somebody puts them on the wrong statin, one that's metabolized by the liver, or doesn't recognize when they're changing drugs that they've changed from a HIV drug which doesn't affect the cytokines to one that does, they can get rhabdomyolysis. If they take sildenafil, they can get hypertension. There are numerous cases of people getting drugs for migraines who get strokes, quinidine, prolonged QT syndrome. So again, just think in terms of drug interactions, because that, again, is something that is very easy to ask on the boards. And again, look for ritonavir here, look for the D drugs for septic shock up here, and look for abacavir for this hypersensitivity septic shock here. And again, I think in your practice, the real, I think, key is calling an HIV specialist. There are lots of good tables on drug interactions, but they're very confusing. And again, unless you're familiar with the antiretroviral drugs, it's very hard to figure them out. Now, another issue that often comes up with patients with HIV is what do you do about their antiretroviral drugs? If they're on them, do you continue them? If they're not on them and they have an opportunistic infection, should you be starting them? Well, first of all, as most of you are probably aware, in this era of highly active antiretroviral therapy, almost everybody is on 3 oral drugs. None of the drugs are parenteral except for one that's not very used very often. So either you have to give them orally or you can't give them. And the problem with HIV drugs is that unlike most of the other antibiotics you give, if you give HIV drugs and the drug levels are too low, you can very rapidly cause resistance, which will invalidate those drugs for use in patients for the rest of their lives. So it is better to take them off the drug so that they don't have exposure and don't develop resistance than it is to keep them on with suboptimal levels. And because very few hospitals in this country do real-time assays for antiretrovirals, if you have a patient who comes into the ICU and you don't think their GI absorption is going to be reliable, it's better to just stop them. Because that's something, again, they could ask you on the boards, but if you have unreliable absorption, the concern over development of resistance is substantial, and you don't want to invalidate a class of drugs for the rest of the patient's life. So the other issue, of course, is not only is absorption is a problem, there's so many drug interactions. Again, most of the time, it's better to stop antiretrovirals if either absorption is uncertain or if the drug interactions, which are almost always will. The other thing, which I think is probably not a fair board question because there isn't really consensus, is if you have somebody who's never been on antiretrovirals and they come into the ICU with pneumocystis or cryptococcal meningitis, the question is, should you start? For the same reasons up here, you're hesitant to start because, first of all, you don't know if they're going to absorb it, there are going to be drug interactions, there are going to be overlying toxicities. So it's really not an ICU question. You probably should not start them in the ICU. Somebody else will start them afterwards. And whether you start them a week after their pneumocystis or a month, I think is still controversial. You should start them sooner rather than later. There are studies that show that. But probably the ICU is not the optimal place to either continue drugs or to start them if they haven't been on them before. Now, again, I said that I wasn't going to review opportunistic infections in general, but because pulmonary disease is common, I just want to make a couple of points about pulmonary disease. It's important to realize that among patients with HIV, while we think in terms of pneumocystis, in fact, the most common complication of HIV is not pneumocystis, it's pneumococcus. So that pneumococcal infection of the upper respiratory tract, sinusitis, otitis, pharyngitis is very common, and pneumococcal disease of the lower respiratory tract, pneumonia is very common with more empyema, more bacteremia. So keep in mind, pneumococcus, there's more and more cases of staphylococcus, including MRSA, although Haemophilus was in the original definition of AIDS. Because children are immunized with Haemophilus, there's less Haemophilus now in the community. so that due to herd immunity from immunizing children, we don't see much Haemophilus disease in any adults, and it's certainly much less common among patients with HIV. So after pneumococcus and staph, you think about pneumocystis, but again, you're going to be able to distinguish one from the other based on the purulence of the sputum, how acute the onset is, what the radiologic pattern. That should be a relatively easy differential. TB in this country, very uncommon, although HIV-infected patients are more likely to get TB than other patients. In this country, we almost exclusively, we only see about 13,000 cases of TB in anybody per year. Most of those patients are either foreign-born or have been incarcerated. So again, you can look for a case of TB on your boards or in your practice in somebody with HIV, but it's almost always going to be somebody who has a risk factor. It'll be a subacute onset, but the radiology in the sputum will be very different from somebody with pneumocystis. And lastly, don't forget that people with HIV are not immune from influenza, mycoplasma, Legionella, so make sure you work them up for those, you consider those in your differential, and if they're sick enough, that you treat them for those. Keep in mind also that if you see somebody with HIV, while there's some uncommon things, what never causes pneumonia in a patient with HIV, and when I say never, I mean almost never, some of you may have seen some cases, CMV, Mycobacterium avium, and HSV are important pathogens in patients with HIV, but they never cause pneumonia. Mycobacterium avium causes bacteremia, CMV causes retinitis, CMV causes pneumonia in transplants. You'll hear about that from Rick Childs, but they do not cause pneumonia in this population. So if you see on the boards or you see in your practice somebody with a diffuse pulmonary infiltrates and they have CMV by culture or PCR, if they have HSV, if they have MAC, almost always you should look for some other cause of pulmonary dysfunction. That's almost always going to be an airway colonizer and nothing more. Again, are there some cases of pneumonia due to that? Sure, there are a few, but there are only a handful in the last 20 years. So again, think of bacterial processes, remember pneumocystis, but again, remember they can also get the usual atypicals and viral things that are in the community. Now, when somebody presents with HIV who has started antiretroviral therapy, one syndrome you should consider as you're thinking about opportunistic infections and tumors is the so-called immune reconstitution syndrome. And this is a syndrome that occurs days, weeks, or months after they start antiretrovirals. It's because they have such a good response in terms of their immune function getting better, and again, it can happen within days, that if they have any antigen or live organisms anywhere in their body, it will flare. So here's an example, somebody who presents with, actually the infiltrates don't show up so well, they have HIV, hypoxemia, diffuse infiltrates, their bronch showed pneumocystis, they're started on trimethoprim sulfa and steroids, prednisone. Remember, prednisone is part of the regimen for severe pneumocystis with a PO2 on room air under 70. The patient gets much better. The patient is out on the floor. The patient says, I want to start antiretrovirals. They start them. And then a week later, the infiltrates are back. Now, you can't absolutely prove in one case that this is not due to some virus or something else that just wasn't defined, but there have been enough cases where there's lung pathology that it is clear that this is caused by a brisk inflammatory response to the antigen of dead organisms that's sitting there, and this can be life-threatening. And it all depends what antigen you have. If you had pneumocystis, you can go into respiratory failure. If you had cryptococcal meningitis, even if it's controlled, the cryptococcal antigen that's still in your meninges can get inflamed and you can get very severe aseptic meningitis. You can have all sorts of things, lymphadenopathy. So just keep in mind that if somebody has started antiretrovirals in the days or weeks prior and they've had a good response, the syndrome you see has to be worked up for infection and tumor, but it may be an immune reactivation syndrome or IRIS. So this occurs days, weeks, or months after initiating antiretroviral therapy. It occurs when the viral load falls. You may not see a CD4 count increase. And again, you have to rule out infections. This is really a rule-out diagnosis. So let's switch gears for a moment and look at another thing. This is a 35-year-old physician who presents to the emergency room with fever and hypertension in July. Again, we're switching from HIV, so this is not a trick question about HIV. He lives in Southern Virginia. He has headache, fever, and malaise for 5 days. He comes in hypotensive, tachypnic, with a respiratory rate of 30. He has some petechial skin lesions and a necrotic skin lesion we'll see in a minute. He has a bandemia, but not much of a leukocytosis. Platelets are low. They used to be normal. He has a little bit of LFTs, and this is the lesion that he has on his skin. So the question is, what would you prescribe? Now, in real fact, you'd probably prescribe all of these, so I won't accept E, because in fact you don't know what this person has, and the question is, what am I thinking? But the question is, with that SCAR, what am I thinking? Because the point here is, we often treat patients empirically with broad-spectrum antibacterials. You have to think of some of the things that are going to be missed by this. So let's start the timer. And this is not a good board question because this is, what am I thinking? All right, so let's see. So what am I thinking? So again, most of you knew that I was thinking about Rocky Mountain spotted fever or once in a while some other lookalikes. So the question is, what infections mimic sepsis and can cause death but don't respond to conventional antibiotics? Some people call these the summer sepsis syndromes. And just keep in mind that in warm weather, there's some things that occur that may not occur the rest of the year. Leptospirosis, this actually was somebody who works in our department who actually had leptospirosis. But this occurs in hikers, bikers, people who go through puddles of water, streams. It's caused by rat urine. And again, I don't want to go into all the details, but this can cause headache, renal failure, pulmonary syndrome, and some patients with very severe disease will get hypertensive, get distributed shock. It is a cause of a sepsis syndrome that responds to doxycycline. There are these other tick-borne diseases. Rocky Mountain spotted fever I'm going to tell you a little bit about because that is the most feared. But that, again, is something that presents with fever, hypertension. Sometimes, we'll get into it in a minute, it's not always spotted. You don't always see petechia. So the problem with Rocky Mountain spotted fever is most of the cases are not in the Rocky Mountains. And by the time the spots occur, the patient may be almost dead. So you don't want to wait for that. But they are usually febrile. There's some other tick-borne diseases. And although I'm not going to go into detail about other things that can cause fever, just keep in mind that more and more we see people coming back from abroad with malaria. So if you don't ask them about travel, they're not going to tell you about travel. So ask them where they've been. Obviously, if they're a foreign national, you have to ask them if they've been home, because most foreign nationals don't take their prophylaxis when they go home. So you have to get a peripheral smear for malaria or for babesia, another tick-borne disease. And also keep in mind for a sepsis-like syndrome, now these two do not respond to doxycycline. Another one that occurs mostly due to travel, but now there's outbreaks in Florida and Texas is dengue. Can't be treated. But again, these are all syndromes that can mimic sepsis. If you don't get a blood smear, you won't notice malaria. If you don't take a history, you won't know about dengue. And these other three, you need a history, but they do respond, or these other four, to leptospirosis. So make sure you ask about ticks, travel, pets, and avocation like being a triathlon or being a fisherman and wading in streams. So let's talk about Rocky Mountain spotted fever. Here's somebody with petechia. You might be thinking meningococcemia, pneumococcal sepsis, staph sepsis. The problem here is this is a late manifestation. The spots of Rocky Mountain spotted fever are often missed. They're missed in people who have dark complexions in African Americans, but often they don't occur until the 4th or 5th day when the patient is very sick. Rocky Mountain spotted fever, as you can see, is not confined to the Rocky Mountains. It may have been originally described there, but it occurs all over Maryland and Virginia are two of the most common places. But you see Canada, some areas of South America included. Rocky Mountain spotted fever looks like any other kind of sepsis. The rash, again, can be late. and it can be missed, so don't count on this, but fever, headache, nausea, vomiting, abdominal pain, this can look like a lot of things. In the summer, when people may have been outside, may have been bitten by the dermacentor tick, they may not have been realize that because it only has to stay on you for 6 or 8 hours. You have to think about this. So again, if you don't think about this and start doxycycline as part of your empiric regimen, the patient's going to die. So there have been a fair number of cases. They're particularly common in children. And again, you can see deaths really in any age group. So the point of that section was think about these summer syndromes, leptospirosis, Rocky Mountain spotted fever, Ehrlichia, and anaplasmosis or other tick-borne diseases that also respond to doxy. Think about these because, again, they can mimic sepsis. And again, the point about malaria and babesia is there are other diseases that you have to take a history for and look for on a peripheral smear as red cell parasites. Now, in this course, we don't really talk about C. difficile. I know that all of you deal with it. I wanted to just make a couple of points. There's obviously been a lot of new literature about new strains of C. difficile, and it is true that the strains we're dealing with now produce more toxin due to some gene deletions than prior strains, so that we see more C. difficile, we see more virulent C. difficile, and again, there's a molecular and toxigenic reason for that. But keep in mind that not all antibiotic-associated diarrhea is due to C. difficile. C. difficile is a subset that involves the colon. Antibiotic-associated diarrhea is very common, and we need to really be relatively certain about what we're dealing with for epidemiologic reasons, although I know that when patients are sick, empiric therapy has been the norm. I think that largely that's going to change because the diagnostic test we had before, the ELISA, is being replaced now by a much more sensitive test, the PCR. So keep in mind that not all antibiotic-associated diarrhea is due to C. difficile. C. difficile is associated for about 10 to 40% of antibiotic-associated diarrhea, and most colitis, most disease that is confined to the colon, is due to C. difficile. There are some other strange cases which I think are more the province of ID people, but I think, again, if it is disease that on a oral contrast CT is confined to the colon, if there really is colitis inflammation, it's not run-of-the-mill antibiotic-associated diarrhea due to change in flora. If there's inflammation in the colon, then C. diff is highly likely. Now, what is the approach to diagnosis? In many hospitals, the ELISA has such poor sensitivity that people treat for C. difficile regardless of the test, and I don't think that's unreasonable considering how poor some of the cheap ELISAs, how poorly they perform, and again, many hospitals, because they're cost-conscious, don't get the better test. But I think what that's being replaced by, which will not be on the boards, are PCRs because they're not standardized. They're very sensitive, but like with all polymerase chain reaction tests, we're going to be dealing with the fact that they're so sensitive, they'll probably pick up some people who have so little toxin that their bowel disease is due to something else. And that's more of a problem when you're dealing with colitis, not so much in your general ICU patients, but when Rick Childs talks to you about stem cell transplants, distinguishing C. difficile from CMV colitis is a real problem. I think PCR may wind up being too sensitive there, but in any event, a negative PCR will be very good for ruling out C. difficile initially. Just remember that you do not do any of these tests as a test for cure because the toxin remains in the stool long after the patient is better. So don't look at this as a test of cure, just look at it as a test for the initial diagnosis. Another thing to look for in the ICU is a patient with leukocytosis for no clear cause. There are patients who have C. diff colitis who do not yet have advanced enough disease to have diarrhea, but if you do a toxin assay, they will have C. diff. So hospitalized patients with C. diff diarrhea generally have a white count of 15,000, but if you have a white count of 15,000 or higher, and they don't have any other etiology, consider getting a C. diff test even if they don't have a liquid stool, because some of those patients will have C. diff, and if you treat them early, they'll avoid some of the complications that occur later on. In terms of treatment, we're all aware of the fact that we have metronidazole, vancomycin, and combination therapy. Metronidazole is really not a drug you should be using in the ICU if the patient can take and absorb, it's not a drug you should be using if the patient can take oral vancomycin. Metronidazole in some head-to-head studies is not as good as vancomycin. The problem with vancomycin is oral drug is very good, but if the patient has no GI motility, it is not so clear that IV vancomycin is effective. So if their GI motility is poor, give them oral vancomycin and IV metronidazole. And in fact, for most patients in the ICU with severe disease, combination therapy is recommended over single therapy. So combination therapy is the most potent, but in the ICU it really ought to be either combination therapy or oral vancomycin. Metronidazole is only for non-ICU or for very mild disease. There are some new drugs, but none of these have a well-identified role, and I think particularly for the boards you don't need to know anything about them. And I think that although the slide is there, I'm going to move on to the last topic, because treating recurrent C. diff is really the province of ID people, and there's nothing that is proven to work. This is what the Hopkins group uses. I think this is probably reasonable, but there isn't evidence as to what the best regimen to use for somebody who recurs twice, 3 times, 4 times after a good course of metronidazole and vancomycin. So this is the last case, a 29-year-old male admitted to the ICU from the ER where he had pneumococcal meningitis by gram stain. The optimal antimicrobial therapy while awaiting the culture, since you only have a gram stain, and susceptibility would be what? So we're only talking about antimicrobial. We're not talking about steroids yet. Okay, so good. So most of you knew that there is enough pneumococcal resistance, and there is a lot of debate about what the clinical significance of beta-lactam-resistant pneumococci are, but all the guidelines now suggest that for pneumococcal meningitis, until you know it's beta-lactam sensitive, that you should add vancomycin. And again, it's a much more complicated debate than this, but I think that's what all the guidelines would suggest. So you should know 2 things. One is about antibiotic therapy, the other is about prednisone, and then I added one other slide that's not in your handout about fungal meningitis. But basically we're talking about empiric therapy treating for pneumococcal and meningococcal disease in most patients. So you use ceftriaxone and vancomycin until you know the susceptibility. If it's somebody who is older or immunosuppressed, you add ampicillin for listeria because ceftriaxone is not adequate for listeria, so you shouldn't remember to add that. So again, I could see them easily asking you about listeriosis in an older person. But again, remember that listeria should have a clue, and that is listeria is unlike other causes of meningitis. It causes a meningoencephalitis. So it's not that you see, well, you do see headache and stupor, but in addition, typically with listeria, you will see confusion. So it's a combination of encephalitis and meningitis, so that should be the clue. But if it's an older patient or somebody on steroids, think of listeria, think of the gram-negative rods if you see those, and then you add ampicillin. Think of gram-positive rods. The last issue about bacterial meningitis is dexamethasone. Should you use that? In children, I think there's been a good study on neurologic and auditory sequelae of meningitis showing that dexamethasone will reduce the complications. And the criticism is that this was in children. It involved an organism we don't see anymore. But I think the biology is plausible to use it in other situations. I think there are good studies in adults suggesting that you can reduce sequelae if you use steroids as initial therapy before you give antibiotics. There has been some controversy, and there are some well-publicized articles in the New England Journal suggesting that steroids had no effect. But I think that's really not relevant to the United States because many of the patients either were not tested for HIV or they came in very late in the course or they were using different antimicrobials from what we use here. So I think in this country, when you're dealing with bacterial meningitis, certainly if you have somebody with moderate to severe disease, and perhaps in anybody, if you can start them before or just at the time of the first antibiotic dose, consider using this regimen. I think now the consensus is this does reduce the neurologic sequelae in adults as well as in children. The last issue is just to remind you that in addition to bacterial meningitis, patients who come into the emergency room, patients who come to your ICU may have cryptococcal meningitis. 20% of patients in this country with HIV are not aware they have HIV, so patients have to be tested. If patients have steroids, they can have cryptococcal meningitis. But also keep in mind that cryptococcal meningitis once in a while occurs in people who appear to be normal. There's really fascinating work looking at whether these normal people are really normal or whether they have subtle immunologic defects. That's not really an issue for a critical care board, but keep in mind that anybody with meningitis could have cryptococcal disease. You have to make sure that you include in your spinal fluid evaluation either an India ink so that you can see the encapsulated organisms, or what most labs do for the last 20 years, do the antigen. Almost everybody with cryptococcal meningitis will have both a blood or a serum and a spinal fluid antigen that are positive. Almost no one will be negative if you have a good laboratory. So either blood or spinal fluid will be positive. And just remember that in terms of therapy, fluconazole is not the right choice in the United States. It may be the right choice in other countries that don't have liposomal amphotericin. The right choice for the first 2 weeks is liposomal amphotericin. There is no question about that. And you may also want to, in your TAP, monitor the intracranial pressure. If the intracranial pressure is over 25 centimeters, you want to consider doing daily TAPs, which probably improves prognosis. But again, in addition to the usual causes of bacterial meningitis, remember to look for listeria, either in your practice or on the boards in an older person or somebody on steroids, and look for cryptococcal disease, and make sure you do the appropriate diagnostic tests and you use amphotericin and not fluconazole. So with that, the question is, who won the award today? And let's see whether we'll find out by putting it up on the